Maurer, the Executive Director of the Maine Council on Aging and the Program Manager for the Tri-State Learning Collaborative on Aging, and welcome to our second to final ECHO session, and it's been quite a journey. So just as a reminder, one last time, if you can use your camera, we would love to see you. Please keep your phones muted if you're not speaking. If you're on the phone, it's *6 to mute, *6 to unmute, and please put your name in the chat box for attendance. And so we are going to start right away today with our didactic presentation by Ellen Flaherty and Renee Pepin, who are going to be talking to us today on really a topic that is a terrific carryover from our conversation last month. And I guess I will just take a step back to say that all of us were greatly impacted by the presentation last time. I think most of us have had some follow-up conversations and some some thoughts and feelings about our last ECHO session. So we're really, we're very lucky to have this presentation on end-of-life care and dementia, what matters most, following on that ECHO session to really help us think about more about end-of-life decisions and how we can be thoughtful about those. So I'm going to turn things over to Renee and Ellen, who are from the Dartmouth Centers for Health and Aging.
Great. Thanks so much, Jess, and thanks to everyone. As I mentioned to Jess, as she did, the case that was presented on our last session was really very impactful. And so today we're going to focus on kind of how we operationalize what matters most to really ensure that the care that we provide is what we call concordant care with somebody's wishes. Next slide, please. So just to give you background, Dartmouth Hitchcock is part of the is an age-friendly health system, and the age-friendly health system is an initiative that is funded by the John A. Hartford Foundation and is implemented through the Institute for Healthcare Improvement. And the age-friendly health system program model focuses on what we call the 4 M's. Which is a set of tools that we use that focuses on, most importantly, number one, what matters most to patients, medications, mobility, and mentation. And so we have worked hard in thinking about this, certainly in primary care at Dartmouth, and through some of our initiatives in long-term care that I will touch on a little bit. Next slide, please. Renee is going to talk a little bit about why what matters most is really the most important M.
Okay, so I had a little bit of trouble unmuting myself there, but I hope y'all can hear me now. So we really feel like the what matters most is the heart of the 4 M's, and that's what we really, really need to focus on. And there are several reasons for this. So probably most importantly is for older adults who are receiving care. So there is a lot of variability in terms of what matters most to an individual that we're working with. So we really need to understand what's most important to them to help us guide care. We can't really assume that it's the same for everybody. We do know that by eliciting what matters most and letting that guide our care, our participants feel more engaged and they feel like they're listened to, which is really, really important to them. And it helps avoid unwanted care, right? So we avoid giving people care that they don't want, and we're able to focus on giving them the care that they do want. It's also really beneficial for the healthcare system. We know that better patient experiences lead to better scores, and people stay with us for their care. And it helps us avoid unnecessary utilization, which helps a healthcare system save money. And really, it impacts everybody. It's better for everybody if we focus on what matters most to our older adult patients. And when we say everybody, some examples of who we're talking about are patients, their caregivers, other providers, other people who are a part of the healthcare team, the system at large, the community, everybody who's involved with the care of someone, to ensure that we're all on the same page. So we all know what this person's preferences and expectations are through their healthcare journey. It's going to help us have improved relationships, minimize conflict, making sure that everything's moving together smoothly. And for us, we really think about what matters most as the basis of everything else. And it's at the core of all the M's and all of the care. We want to make sure that our care is being guided by what's most important to the participant or the patient that we're working with. Next slide.
So when we think about achieving person-centered care at the end of life for folks with dementia, we're going to really focus this presentation on, as I mentioned before, how are we operationalizing this? So most of our patients with dementia have a surrogate decision maker. And generally we think about that as a DPOA, or durable power of attorney for healthcare decisions. Many states have surrogate laws. So certainly in the states where we're working, we look toward surrogate laws to help make decisions about patients when they don't necessarily have it clearly spelled out. And the DPOA is generally activated, and that is kind of an official act that's documented in a record. And that can be done by a physician, a nurse practitioner, or a PA. And when we take the steps to activate the durable power of attorney, that's really based on the patient's capacity to make these complex decisions. And when we think about decision making and cognitive impairment, certainly people even with severe cognitive impairment have the capacity to make decisions about what they want to eat or whether they want to eat. And generally, even in moderate stages of dementia, patients can tell us who they want to help make their decisions, who they would want to designate to make those decisions. And those are less complex decisions to make. When we start to think about transferring somebody or what kinds of care they want to receive in the hospital, and understanding what the pros and the cons of that are, that becomes much more challenging. And so we look to surrogates to have these conversations and to have what we call the goals of care conversations. It's really important to think about this in a systematic way, and not only having the conversations, but how are we systematically documenting the goals of care? And we do that in a number of different ways. And today we're going to talk about the POST, and we're going to also talk about the Dementia Directive, which many of you are aware of. We like to think about this in terms of systematically having these conversations before an acute event, before any acute episode. As many of you who work with patients and patients' families know, that at 3 in the morning when we get the call that somebody is in distress, that is generally not the best time to have the goals of care conversation, although we do that very often when we don't have goals of care documented. So we think about this before an event, right? So we think about things like transferring to the emergency department. What is the level of intensity of care that somebody wants? Do we move towards hospice? And how are we documenting the intensity of that care? Next slide, please. So as I mentioned before, in terms of surrogacy and a durable power of attorney for healthcare, there's also the legal guardianship and also a power of attorney for finance, which this is not. There are situations where people have legal guardians. And in our experience, what we have found, and certainly love to talk more about this, is that legal guardians tend to be very conservative. And because they don't necessarily know what someone's wishes are, we tend to, I would say, provide a lot more aggressive care than we would if somebody has a next of kin. Next slide, please. So a POLST or a COLST or a MOLST, depending upon what state you're in, is provider orders for life-sustaining treatment. And I think orders is the word here that we really want to focus on. This is a national movement. It focuses on implementation and utility. They are state endorsed, and the broad category.
Can I interrupt for just a minute? There's a really loud chirping on in the background. I'm not sure what that is.
I think we got it taken care of.
Okay, maybe that was a sign. So when we think about the broad categorizations of goals of care, we think about it in terms of full, limited, and then comfort care. So specific choices that we talk to patients' families about is specifically CPR, hospitalization, and then IV hydration and feeding tubes and antibiotics. This is an order, so it is actually signed by a provider. And what that enables us to do is to use this as what we say also a portable document. So this is an order that is carried out, and is carried out not only by providers taking or staff taking care of a patient, but in terms of, say, EMTs and ambulance drivers, and then what happens in an emergency department as well. Next slide, please. So when we have these conversations with patients, very often what we do actually is have the form in front of them. I'm going to talk a little bit later on about a project that we're currently doing with medical students and surrogates for patients in a nursing home in New Hampshire, and having these conversations. So when we think of the POLST and somebody who wants full interventions, that means CPR, hospitalizations with unlimited care, IV fluids, feeding tube, and antibiotics. And as I mentioned before, sometimes this is what we see in terms of legal guardians and wanting this kind of full-blown care. Next slide, please. So the next category is limited and what we call kind of no heroics. And this is a person who tolerates the hospital fairly well and definitely wants some treatment, but as we say, no heroics. So a lot of people fall into this category. So when we have these conversations with patients and families, and we think about quality of life, which, as we all know, is something that's really very difficult to judge in terms of someone else. But generally speaking, families really have a good understanding of somebody's quality of life. And when they have a reasonably okay quality of life, even with cognitive impairment, and they feel that a short-term hospitalization or short-term antibiotics would help somebody to get back to where they were during an acute illness and be able to function in their where they have been, then they say, you know what, let's do this. Let's have somebody go to the hospital for potentially for a few days, and let's see where we are with antibiotics and what we can do. However, we still don't want CPR, and we don't want this person to wind up in the intensive care unit. Next slide, please. When we think about limited, we kind of call this certainly treat in place. And again, that does not mean that we're not going to treat somebody with what we can do at their site of care. So whether that's at home, whether that's in a skilled facility or an assisted living facility, we know that there are some things that we can do. For example, we can generally get blood drawn. We can very often provide intravenous hydration. And certainly, you know, in a lot of urban areas in the country, we can get, you know, x-rays and even ultrasound in someone's home. So there is a fair amount that we can do in terms of treat in place. So these are mostly for folks that have said, you know what, I don't want to go back to the hospital. Mom did so poorly the last time. She was really delirious and combative and needed restraints. And it was just a terrible, terrible experience. But if she got sick, I think, we would definitely want her to be treated at home or in a facility. And let's see where that gets us. Next slide, please. So when we think about comfort care, that's as we enter into kind of the end of life, right? Or people who have said clearly, and we're going to talk about this Dementia Directive, if I have dementia, or the surrogate, the daughter or the son will say, I know that mom, who is functioning okay, but is really her quality of life, or my dad's quality of life is really nothing that where they would want to receive any kinds of treatment. And how do we think about that in terms of comfort care? Well, very often we think about that in terms of hospice, and really setting up a plan of care where somebody can receive not only medications, but non-pharmacological approaches to whatever symptoms that they have. This would include certainly DNR. And it's not that these patients never get hospitalized, but at times what will happen if somebody, for example, is somebody who is on comfort care, and even somebody who is a hospice patient falls and sustains a laceration of their head, the bleeding just can't be stopped. Then that would be an indication to send somebody to an emergency department. On our team, generally what we do then is we pick up the phone and call the ED, and we say, patients coming in, no MRI, no CAT scan, please sew them up. If you're thinking of doing anything else, please call me back. So somebody will go to the ED, receive whatever acute care that they need at that point, and then are sent back. And we'll talk about that a little bit more. Certainly no feeding tubes, and antibiotics only for comfort. This can get a little bit tricky. Obviously, there are people who have significant urinary tract infections who are not comfortable. And in that respect, we should treat them. If somebody has a pneumonia and they're comfortable from a respiratory perspective, then we would certainly opt not to give them antibiotics for that. But again, a lot of this is pretty gray and is managed generally on an individual basis. Next slide, please. I wanted to talk a little bit about the Dementia Directive, and many of you, I'm sure, have seen this. It was published in the New York Times, came out of the University of Washington. Here is the website, dementiadirective.org. And it is a supplement to any advanced care plan, and can also be a supplement to what we usually do in terms of any advanced care plan in any of the states where we live. And what this enables patients to do is to think specifically about dementia and the types of care that they would want. And again, it's very similar to the POLST in terms of 4 categories of care addressed for each of the 3 stages of dementia. Next slide, please. So the 4 main goals that are offered in the Dementia Directive, again, are very similar to the POLST, but you're generally, this is being completed by people who are healthy, people who have capacity to make decisions. Very often we get requests, especially from family members who have cared for a loved one and have said, I don't want to go through this. I would not want to live. And I also don't want to burden my children or my surrogate with having to make some of these decisions. So I want to make it very clear that should I have mild, moderate, or severe dementia. We're going to go through that. This is the kind of care that I would want. So again, the first category, to live as long as I could. So back to the pulsed and kind of full care, to receive treatments, but no heroics. So again, hospitalization, but no ICU, no CPR. To receive care in place. Again, very similar to what I talked about in terms of the pulse. And the fourth, to receive comfort-oriented care only. Next slide. So I just wanted to touch base a little bit on the model that we've been using at Dartmouth that we developed. In providing not only primary care, but the medical directorship of 4 nursing homes within close proximity of Dartmouth Hitchcock. About 5 years ago, a team of us sat down and we said, wow, there are so many patients that are being transferred. And, you know, we all know that these patients don't likely want to be transferred, and that what happens, and this happens, of course, across the country, is that when somebody has an acute episode at 3 in the morning and primary care is called, generally speaking, that primary care provider does not know the patient. Very often, that primary care provider has never stepped foot in a nursing home. They do not know the nurse. They do not know the patient. They don't understand what's happening. And rightly so, what happens is they're like, I cannot manage this. I do not know what's happening or the risk for this patient, nor do I know what this patient wants or doesn't want. So the default is send the patient to the emergency department. We also find, as you know, that the staff in general, when we think about nursing, for example, and staff shortages, when we have a staff shortage, the hardest hit places are generally long-term care facilities and certainly home care. So as we are presently in an acute nursing shortage and an acute workforce issues, as we've talked about many times on these calls, is that very often we have not only they are understaffed, these facilities, but the staff that are there, as I say, potentially is, you know, a licensed practical nurse that has had limited training and has actually been a nurse for 5 minutes. And this nurse has 40 patients that she is or he is caring for. And so when somebody gets sick and has an acute event, very often it's much more comforting for the nurse to call 911 and not have that patient stay in the building. However, what we do know is that when we ask nurses, very often they say that way too many people get transferred and they would really prefer to keep people in the facility. So we developed this model called reducing avoidable facility transfers. And there were really 3 components to this model. As I've talked a lot about what should happen before the event. So every patient in the facility, when they are admitted, we have a goals of care conversation. And I just want to point out that this is really a team effort and generally starts with the social worker in the nursing home. And while the ultimate goal is to execute a PULSE, which again is a physician or provider order, very often the social worker starts those conversations with families. And very often nursing gets involved to have those conversations with families. And so I would say probably 50% of the time, what happens is the social worker is able to have that conversation and come back to us and say they want limited care or they want on-site care, or and when we get to know the patient and we think that that's appropriate, we sign off on the orders. It's not that we don't verify that with the families, but this really is a team approach. During the event, it is imperative that we get called first. So I have to tell you, we have this kind of unique practice in that we take our own call from the geriatric team. So these are geriatricians, geriatric nurse practitioners, so people who are kind of content experts, and we get the calls first before a patient is transferred. And that really, really helps, because if the nurse calls the families first and says, your dad is having some significant respiratory distress, do you want to transfer them to the hospital? Well, again, potentially the daughter is sitting somewhere in California and says, yes, of course, my dad's not comfortable. When we get that call first and we are able to go to where we've systematically documented what a patient wants in the record, then even if I'm on call and I've never seen that patient, I can go back to that documentation and call the daughter, have the conversation with the nurse to say, you know what, why don't we try this first, right? You have comfort orders. How about we try this? How about you, let's do a Duonap. Let's give him some morphine, and I'm here with you. So I'm going to call you back in 15 minutes. So it's not this, I don't know who you are, send the person to the emergency department, but I'm here for you, and we're gonna do this together. So it's a team of people understanding where the nurses are, what's happening in that facility, and knowing specifically what kinds of care can be provided in that facility.
And I just want to emphasize one really important point. It's for this model is that the goals of care conversations happen and that they're getting documented, right? So Ellen's talking about this really systematic approach so that we know that these conversations are happening in a relatively structured, systematic way. And then equally important that they're getting documented. So whoever picks up that ball knows what this person's preferences are.
Thank you, Renee. That's really, really important. And I think as we think about this work nationally, I think, you know, one of the biggest challenges, of course, is how this is operationalized in facilities, how this is operationalized in electronic health records. And then after the acute event, every case that's transferred is part of a case review. Next slide, please. So here are some of the outcomes. So again, these were 2 skilled facilities, and you see that there is a 72% reduction in transfers in these facilities, which, as you know, also translates into a lot of healthcare dollar savings. The impetus to do this was not savings. We are not an ACO, unfortunately, at Dartmouth. So all of this work actually takes revenue away from, potentially away from the hospital. But as we move toward value-based payment, this will absolutely make a lot more sense. Now, this makes a lot more sense in terms of, again, concordant care. Next slide, please. So, in conclusion, I think my takeaway points, and then I'm going to just call on my colleague, Dr. Pepin, to just also give her her thoughts. Eliciting goals of care with systematic documentation really is what's needed to ensure end-of-life care for people with dementia. I think, again, constantly thinking about this as pre-acute illness planning, and then at the time of the acute illness, being able to implement that plan. So with that, I'm going to stop and see if Renee wants to give her final thoughts.
I think that the only thing I have to add is that this is really at the heart of the care that we give for people, particularly people with dementia, and to really understand what people's preferences are is so important so that we can drive care so it can be in alignment with people's preferences and wishes. And the sooner we get that documented, the sooner in somebody's process through dementia, we can get that cleared away, the more confident we can be that we are doing things that are consistent with what this person would want.
Thanks, Renee. And we'll turn